Okay, hello. In this conversation, I want to talk about how data and artificial intelligence is used in healthcare and how hospitals and governments are using now data to predict the pandemic, to predict ICU and intensive care capacity during COVID-19. And I am very pleased to say that I'm here with Orlando Agrippa. Orlando is the CEO of Draper Dash, a London-based healthcare AI and machine learning company that focuses on predictive data and analytics. So, first of all, hi, Orlando.
Hey, Bernard, it's a pleasure to speak to you today.
Yes, same here. So, what I would love to learn more about is how do healthcare organizations now use data in this current pandemic to really predict, and what sort of data are they using? Have you got any good examples?
Yeah, so the normal day job is pre-COVID is to work with hospitals as a kind of venture-backed predictive patient flow business to help them with lubricating the operational vertebra of a hospital. And what that translates to in sort of normal terms is, how do we help Orlando Agrippa, AV breaks his arm, turns up to the ED, and then needs to be admitted? How do we help to predict how long he might be in a hospital bed? What might be the underlying things causing Orlando to be in that bed? And how, more importantly, do we get him discharged out of hospital effectively? Because hospitals are sort of holding patterns and are never the greatest place for patients to be long term, right? So that's what we do normally. In terms of where that's changed, and to your question of how people are using, or how hospitals are using, or health systems are using data at the moment. So as we saw the emergence of the virus before it became a pandemic from Wuhan, we thought earlier this year, how do we flip this technology on its head to be able to help hospitals to see into the future and plan ahead, more importantly, on the impact that the virus might have on beds, and more importantly, very, very limited ICU and high intensity sort of beds. What that's led us to is to kind of having a solution that supports that, but more importantly to the question, what we're seeing globally in our customer base in the Middle East, in the UK, is we're seeing hospitals leverage that sort of technology and the data that drives it to be able to work out what is the potential impact that we should be planning for, and what does our capacity look like in terms of not only volumes but complexity, right? So how many of a certain types or category of patients will we be able to see both in the ICU and our general acute beds. So we're seeing data play,
which then allows hospitals to plan in terms of bed capacity, but also personnel and PPE and other things. Is that right?
Exactly. So it's not just beds is a kind of key proxy for things that are happening in a hospital. However, linked to every bed will be a patient, will be the staff that's required to service it, will be the equipment that staff requires, etc., etc. So that's how we're seeing data play a massive role, both at a local hospital level, but also at a system level.
Yeah, very good. So what sort of data are you using for this? So what is feeding your models? Is it internal data, external data, and is it structured, unstructured data? And we talk about data, there's a big question mark around reliability. I've just recently written a Forbes article when it emerged that China, and especially around Wuhan, they completely under reported the death toll. We will see this, I guess, across the world. So what data are you using, and how confident are you in the data?
Yeah, so we know that globally you've got tiers of organizations all working feverishly to be able to deal with this, right? So what you've got is you've got, central bodies like NHS England, Imperial College, great bodies who are looking at the kind of population and the impact there. And we think those organizations are doing a great job. You've then got the kind of regional teams, if you take the UK, across the countries that we're working with, who are trying to distill that data and the models that they've been given down to what does it mean for my population, right? You've then got within those regions health providers who have got to kind of deal with the cold face of the people turning up and ensuring that, as many of us as possible survive this pandemic. So our focus has been more at the sort of latter of those two. So at a very hospital and system level to say, well, actually, this is what we know about your population, about your screening programs, about your R0 rates, right? Your split in population. In some countries that we're working with, we've got a split between your sort of white collar and your blue collar, and the sort of underlying conditions in those two groups are very different, right? So we're working at that level to be able to ascertain the impact and the capacity. The sort of data that we're using is predominantly historical and live. So data from, how is your A&E? What sort of volumes have we seen through your A&E in the last 5, 6, 7, 10 years, right? Your inpatient bed base, what does that look like? What does your actual beds look like before COVID? Now tell us now what your screening volumes look like in terms of real patient numbers. So we're not planning at a sort of a population high level view. We're planning at a granular Orlando Agrippa, Bernard Marr volume and complexity to be able to work out what the true impact might be. We're also, in terms of the reliability and is it structured and structured. So it's a mixture of both. So what we're complementing the live tool with is what is happening globally in terms of what can we find in papers, in different kind of case references or case studies, so that we can bring that together to say, actually, Singapore has done all of these things, and this is the sort of results that we're seeing from what we know publicly. Which of these things should we be considering as well, and which of these things might not work for your population, right? So it's a bit of bringing in structured data from their core clinical systems, unstructured data from kind of public sources, and the reliability. So we only work with organizations before we even engage. We do a bit of a data confidence test to see if the sort of key metrics that we need to go after will be present in the data set and the quality of it is reliable. So if that's not present, then we think that there are other bodies or other firms that might be able to help at a higher level.
Okay, tell me a bit more then about so once you have the data, what sort of technology do you use? What machine learning models do you use in very simple terms? How does this work? So if a hospital came to you and said, okay, we want to use this technology, what do they need to do? Are you hosting all of the technology? Is there a cloud-based solution? What sort of machine learning approaches do you use for that?
Yeah, for most of our customers in the UK, it's a cloud offering. Outside the UK, we have got a mixture of on-prem and cloud. Because some countries, given the pace at which we're moving, getting regulators to approve certain external bodies coming in and in the cloud is difficult. In terms of the models that we're using, so we're using a multitude of models in terms of prediction. We're using the sort of SIR model or SIR model. We're bringing in a lot of R0, so infection rates numbers for countries, and looking at how we match that to specific populations. We've got, from a machine learning perspective, we've got a mixture of distributed models and others, and there's a better team who are the kind of gurus at our models who we should have probably brought onto the school, but I know definitely those are the things that we're using from a core algorithm perspective to be able to drive our predictions. In terms of technology, it's it's multiple things. So from a visualization perspective, we're agnostic. We can bake our insights and analytics through multiple tools, be it Click, Tableau, Power BI, whatever people have got. We're agnostic to that. But the core technology is in our data integration engine, which has got a mixture of all of those things baked into it to be able to do the projections.
Very good. And I believe you're developing scenarios, right? So I guess it's very, very difficult to predict exactly what is going to happen. So you give healthcare organizations different scenarios, is this right? Saying this could happen and that could happen, and then based on more data coming in, these scenarios become then more realistic and less realistic. Is that right?
Exactly. So what we do is we look at, because the great thing about, and it's great in one way and it's very disheartening in another, but one of the things that we do is we look at across the globe, right? Because for years I've been saying to investors and to providers in different countries that we've worked in, healthcare is broadly delivered in the same way globally, right? I know, for example, in China, there isn't a GP system, right? Because it just doesn't work that way. Whereas we've got a massive kind of GP infrastructure and all that. But broadly, patients flow in and out of hospitals in the same way. So for us, what we are looking at is this pandemic is demonstrated that globally, the problems that people are struggling with are PPE, they're struggling with ICU beds, normal beds, and all of the same things, which gives us a great opportunity to learn pretty quickly. So the countries or organizations that have been ahead of us, we have taken a lot of their data and modeled it into a platform to be able to say, if we were to do these things in the way that Singapore's done it, then these are the sort of results that they've had, and broadly these are sort of the results that we might be able to expect, or you might be able to expect as an organization. We then compensate with multiple models to look at your population, your demographic, etc. What we then do is we match our results against other predictions, right? So for example, we know Imperial's got a model which predicted X amount of mortalities. I think it was 350,000 or 250,000 for the UK, and maybe 500,000 or 350 for the US, right? Now we know so far that's not happened, and they were predicting that the peak of that would have happened by June. What we do know, however, irrespective of the volume, that the silhouette in terms of when the peak is broadly going to happen in terms of a range, we're seeing that silhouette consistently across the planet. So what we're doing is matching our algorithm to see, well, does this profile match what other models are saying, and what range should you be planning for? For example, we know some hospitals in the UK have already said, we've peaked, we've seen the worst of it, we're expecting a second wave, and I'm sure we'll come to that later on in the year. However, we need to now start planning for cancer treatments to be accelerated and elective activity. So that's how we're thinking about it, and that's how we've been doing it.
Very good. And being a bit of a data geek myself, I look at exactly the same silhouettes of data across the world. So what do you think? Where are we in the UK? Where is the US at the moment? Which countries do you think have passed the peak, and which ones are still need to prepare? Which ones do we need to prepare for the peak to arrive?
Well, I think there's some good questions in there. So I think the people who are not doing very well are in South America, right? So most of the South American countries have been hit brutally because there's been a mixture of kind of denial and sort of I don't know what the other word might be, right? So they've not done well. Countries who we have consistently seen doing well in preparedness and protecting kind of their citizens have been kind of South Korea. We've seen Singapore. We've seen the guys in Abu Dhabi do a lot to really progress with with ensuring that they've got everything from capacity to screening, etc. So those countries, and there's an argument that population and being able to move the levers across smaller populations is considerably easier than larger populations. I think to your question on who's peaked is a hard one, because I think there's been, so this morning I woke up and Germany's been doing a really good job as well, right? But Germany's infectious rate has gone to something completely different. If you give me a second, there we go, and we might have to edit that out. I will lock it in. There we go, remove. Got a lot of joiners in here. I think it's because of the time. I think there's another, don't worry, it's locked. So we'll probably...
If you talk about Germany again...
Yeah, we'll edit it out.
Yeah. If you start about Germany's doing a good job.
Yeah, so I believe that Germany's doing a good job, like some of the other countries I've mentioned. This morning, I woke up to last night, a lot of news of countries coming out of lockdown because they think it's under control. And then Germany, in the news this morning, their infectious rate grew from 0.74, I think, to 1, right, which is not good. So I don't think that anyone's kind of out of the woods yet. And given your article about the Far East, I don't think that I can rely on the sort of numbers there to be a proxy. I think this is what probably this is what we're seeing in the data, right? That silhouette that we mentioned before, which is kind of May, June, I think that is truly where we should be comfortable around a peak. I think what will then happen is, we will get a bit comfortable because there's not a vaccine yet. We will then, and this is a real challenge, we will then go into the autumn with the seasonal flu plus coronavirus combined. And my sense is that we will have a double whammy of a second wave. So all hospitals across the country and globally are planning for a double hit, a second wave. My sense, and from what we're seeing in the numbers so far, is that wave will be between August and early autumn as this flu virus starts to kick in, right? We know that some hospitals across this country believe that they've peaked and they've moved in, as I mentioned earlier, to delivering elective activity and starting to push that forward, which is the right thing to do, because we're starting to kind of, there's a lot of capacity at the moment in hospitals because hospitals have planned really well and have not been hit because patients have been staying home. However, we're starting to see patients return to A&E departments or emergency departments, and that's a real challenge.
Very good. Last and final question then, Orlando. If you were to say, this is what I find really exciting about analytics and AI in healthcare, what do you see as the future? Where do you see, what are the areas that you think these are applications of AI and data science and analytics that will make a real difference in healthcare in the future?
Well, I think this. Before COVID, what we saw was a real issue around a lack of clinical workforce globally, right? So no country was at its right capacity. So everyone was kind of stealing and borrowing based on who can pay the most money, right? We have seen that with COVID compounded, right? Because the clinical workforce isn't there and capacity isn't there. So we've got those two problems. And then we're dealing with the world's largest elective wait times ever. So, every elective activity on the planet has been frozen until we dealt with this issue, and then we'll have to go back and deal with it, right? So patients on those lists will be deteriorating, some will die, Some, for example, some will lose their sight because after a certain point, there's no point of us operating on your eyes, right? So there's a lot of mess there. I think we won't be able to grow doctors fast enough. We won't be able to, capacity we can grow, but doctors we can't grow quickly enough. So I think what we will see in terms of technology, data, AI, etc., is the acceleration of clinical decision support tools. And before COVID, we saw it with diagnostics, etc. But we will see it more around, how do we help clinical teams to profile patients based on highest risk as opposed to who's been waiting longest, right? How do we help them to, optimize pathways based on what we've seen historically? How do we help with discharging patients faster based on our learning in COVID? So those are the things I'll see. I think we'll see AI and machine learning and technology play a more prominent role in.
Very good. Thank you. Thank you so much for your time, Orlando. That was fascinating, and hopefully I will catch up with you soon.
It's a pure pleasure, and have a great day. Thanks, Bernard.
Thank you. You too.
I'll send this over to you in about 1 hour. Yeah.
Amazing. Thank you.
Bye.
Okay. Cheers.